Good morning to one and all. I am thankful to Chairman Scientific Committee for making me part of this PG program iSala. So before moving to my presentation, uh, I would basically know how many of you, as you all know, dry is a very common disorder and you can say quite undiagnosed condition. Many of basically we go for symptomatic management in most of the cases. Patient of dry eye comes, especially in mild to moderate dry eye. Just we give some lubricating drop and send patient. And we generally tend to do not evaluate in detail. So in my lecture, I will stress why evaluation is important. So in between, I may pose some questions, some simple question to you so that you have some interest in my lecture. So what is ocular surface? It is interface between the functioning of eye and environment. Previously, ocular surface means just only cornea or sometimes conjunctiva, but you see it comprises of tear film also. And you all know tear film is made up of what layers? Three layers. Innermost is mucus layer and middle one is aqueous, then outermost is lipid layer. Okay. What is the thickness of this tear film? Anybody? Around 6 to 8 micron. Okay. So basically this ocular surface serves as a refractive surface. So that is why it should be without any disturbance, without any irregularity, and it maintain optical clarity of the cornea, and again it function as barrier, anatomic, physiologic and immunological barrier. So ocular surface disease consists of variety of conditions, different. It may be just simple dry eye, it may be aqueous deficient, it may be evaporative dry eye, or sometimes some cicatrizing condition, maybe a Steven Johnson, maybe Taine, like that. And there is wide range of symptoms, mostly non-specific symptom, foreign body sensation, grittiness, watering, sometimes tiredness of eye. So there may not be a specific symptom, and it improved the understanding of ocular surface pathophysiology and the limbal stem cell over the last. Currently, previously there was just serums and some more clinical tests, but with the advent of so many diagnostic modality, its understanding has become better, and explosion of diagnostic technique. Although it may not be used in each and every cases, but we should be judicious to know what is the exact pathophysiology. So coming to its prevalence, as I have told, it is quite underdiagnosed condition. So in different study, its prevalence range from wide range, 5 to 50% with or without symptom. And again, when you see in OPD, so many cases of MGD, you will see just simple frothy discharge on the angle of the eye. Just think about you are dealing with a case of MGD. It may be associated with just a aqueous deficient dry eye also, but it gives clue to the MGD. And when you are taking the patient for, especially for cataract surgery, your biometry may be wrong. So that is why these cases should be treated first, and then you should take this patient for surgery. And for cicatrizing conjunctivitis, in 50 to 88% of cases, there is basically ocular involvement. So that is why whenever, especially in dermatology, they have cases of SJS or 10, they should send referral, or you should sensitize them that these cases should be seen by ophthalmologists also, because there may be some cases where uh, uh, symblepharon can occur, or there may be limbal stem cell deficiency. Anatomy has already been covered, so I will not go in detail. I will come to the classification. So, one of the classification of ocular surface disease, that is based on the structure involved. First, the eyelid and eyelashes. It may be trichiasis, districhiasis, entropion, legophthalmos. It may involve lid margin and meibomian gland. There may be anterior blepharitis, or there may be posterior blepharitis like MGD. Tear film, I will discuss in detail, acoustic patient dry eye or evaporative dry eye, or it may involve conjunctiva, chronic cicatrizing conjunctivitis, or SJS, or ocular cicatricial pemphigoid, or there may be limbal stem cell deficiency. It may be primary or it may be secondary. In primary, in cases of congenital aniridia, ichthyosis, acquired mostly occurs due to chemical injury. You will see so many cases of chemical injury. Even in cases of pterygium, there is a, especially double-headed pterygium or large pterygium, there will be limbal stem cell deficiency when you remove the pterygium and you are not replenishing it with conjunctiva, especially when you are taking graft, conjunctival graft, especially limbal side should be on towards the limbus. Otherwise, there is chances of limbal cell deficiency. So, coming to one by one, eyelid and eyelashes involved rigid. There may be trichiasis, districhiasis, entropion, legophthalmos. Coming to the lid margin and meibomian gland dysfunction. So, it may be due to congenital, it may be neoplastic, it may be acute, or sometimes it may be associated with other condition, or maybe due to some medication also. So, it is broadly divided into low delivery and high delivery. In low delivery, there is hyposecretory mechanism, or it may be due to obstructive mechanism. In high delivery, there may be meibomian gland hypersecretion, or it may be associated with seborrheic dermatitis or acne rosacea. First one is, you all know, it is blepharitis. It may be squamous or it may be ulcerative. How will you differentiate between squamous and ulcerative blepharitis? When you remove the scales, there will be bleeding in case of ulcerative blepharitis. In MGD, there will be capping, there may be telangiectasia, and other important finding is, especially when you examine the margin of the eyelid, posterior margin is acute. So, if there is a rounding of posterior margin, it goes in favor of MGD. If anterior margin is obtuse. So, you have to see these findings. As I have discussed, it is made up of three layers: mucin, aqueous, and lipid layer. So, aqueous layer is thickest, and aqueous layer is secreted by which gland? You all know, lacrimal gland and accessory lacrimal gland. So, what are the accessory lacrimal gland? That's good. So, there are different definition of dry eye. It is not that just hyposecretion of tear or absence of tear. So, by different society, especially most important one is Dewey definition, dry eye works of 2. It defined as a multifactorial disease of ocular surface characterized by loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability, hyperosmolarity, ocular surface inflammation and damage, and there is neurosensory abnormality play etiological role. So there are four components: loss of homeostasis, tear film instability, hyperosmolarity, ocular surface inflammation and neurosensory. That is why when you are treating any case of dry eye, there is some amount of inflammation. So when you are treating primarily, always start steroid. It may be just low potency steroid, but always give a steroid for maybe 2, 3 week, 4 week like that in tapering dosage. So again, this is a mechanism of aqueous deficient dry eye, and all these are interconnected. There may be environmental condition, low humidity, high wind speed, there may be high temperature, or maybe lacrimal secretion may be low, there may be high evaporation that lead to tear hypermobility. Then different enzyme is activated, then different interleukins and TNF alpha may be activated, that leads to again goblet cell and glycocalyx mucin loss damage that leads to tear film instability. So this whole cycle runs. There is another classification of dry eye. Again, this is one of the common classification. Dry eye may be aqueous deficient or evaporative dry eye. In aqueous deficient, there may be Jogren syndrome dry eye or non-Jogren. Non-Jogren in primary and secondary. Secondary is mostly associated with some connective tissue disorder. In non-Jogren, there may be lacrimal deficiency, lacrimal gland duct obstruction, there may be reflex block, especially in case of Bell's palsy like that, or some systemic drug, especially antidepressant drug, antipsychotic drug, they may be associated with dry eye. In evaporative, again, it may be intrinsic or may be extrinsic. In intrinsic, there may be disorder of the lid aperture, like you can say ectropion or entropion, eye lag ophthalmos, eye not properly covered by eyelid, or there may be low blink reflex, as I have decided, Parkinson, Bell's palsy. So that will predispose to dry eye. In extrinsic factor, there may be vitamin A deficiency or some drugs that can cause extrinsic dry eye, contact lens wear. So as per different dry eye disease workshop and Asia Dry Eye Society, there is a recommendation how you will diagnose dry eye. So as per dry eye workshop, there should be symptoms of dry eye as well as one of the following: non-invasive breakup time should be less than 10 seconds, osmolarity more than 300 milliosmol, and there may be sign of ocular surface damage. But in Asia Dry Eye Society recommendation, there should be symptoms as well as T-but. Here in dry eye workshop, there was non-invasive breakup time. In Asia Disease Eye Society, they have taken T-but. That should be less than 5 seconds. So coming to the conjunctival disorder, again there is a long list of condition that mainly due to chronic conjunctivitis. It may be due to giant papillary, follicular, membranous or cicatrizing. So you can go through, and all these conditions can predispose to dry eye. Coming to the limbal stem cell deficiency, again it has been covered, I think. So you all know XYZ hypothesis that has been given by Thorpe. So basically X plus Y is equal to Z. So in X basically there is proliferation of basal cells. So it goes upward, and there is by is centripetal movement of the cells, and Z is basically de-squamation of epithelial cells. So there should be balance between the x plus y is equal to Z. So coming to the again cause of limbal stem cell deficiency, it may be acquired or it may be congenital. In congenital, most common is aniridia, keratitis secondary to some endocrine deficiency, especially MEN2, multiple endocrine neoplasia too. So, and acquired mostly occurs with especially chemical and thermal one, multiple surgery, multiple conjunctival surgery can predispose to limbal stem cell radiation, antimetabolite drug, especially mitomycin C. Systemic condition like SJS, ocular secretory cell pemphigoid, vitamin A deficiency. So you can see total limbal stem cell deficiency with it can form granuloma. There may be symblepron. There may be limbal stem cell deficiency can occur with VKC also, vernal keratoconjunctivitis. There may be partial LSCD. If there is persistent epithelial defect, especially after chemical injury, think about the limbal stem cell deficiency. There may be a stippled staining of the on the fluorescein stain, especially on the cornea. Again, it gives clue about the limbal stem cell deficiency. So it may, in especially in cicatrizing conjunctivitis, Stevens-Johnson syndrome, patient may present with true membrane, or then in initial phase, if you are not treating, there can be similar formation. So in this case, amniotic membrane has been applied. In chronic sequelae, there is chronic cicatrizing conjunctivitis. When you invert the upper palpebral area, you can see the whitish membrane like appearance. In any other condition, you will see whitish this condition, just for arousing you. Trachoma, very good. That is called Alt's line. Okay. You can see the lid margin keratinization in severe cases or longer standing cases. So coming to the second part of my talk, evaluation of ocular surface disease. So this can be evaluated just by there are different headings, subheading, tear film volume by Surmer test, ocular surface staining, madam has covered, I think, by fluorescein dye, that is one of the commonest dye we use, rose bengal dye, lesion green stain. Corneal sensation can be checked by simple cotton vest, but there are some instrument, Cosset bonnet aesthesiometer, non-contact air jet aesthesiometer. So before doing test, one should go for detailed evaluation, even history taking. Systemic evaluation is again very important, especially in cases of connective tissue disorder. If you are not taking history and you are just treating these cases, again it will recur, or it may present with severe condition. Lead evaluation can be done by mevography, tear film osmolarity, as I have discussed. One can normal value is less than 308 milliosmol. Tear film interferometry, one can check the precorneal tear film thickness. And non-invasive tear film instability test, that is non-invasive breakup time, lippy view, tear scope one can use. There is a role of intersegment OCT for measuring the tear meniscus height, tear meniscus area, tear meniscus depth. And one can go and check inflammatory biomarker like MMP9 or lactoferrin. So coming to one by one, Surmer test, you all know, it is a quantitative assessment of the tear secretion. So you all know Wattman filter paper, number 41 is used, and its length is 35 and its width is 5 millimeter. So where you will place? At the junction of middle 2/3 and uh, medial 2/3 and lateral 1/3. So again it is of two type 1 and type 2. In type 1 without topical anesthesia, in type 2 with topical anesthesia, and it gives basal secretion, although there is some stimulation from the nasal mucosa, so it doesn't give accurate basal secretion. Okay. So mostly for infirmity I go for with anesthesia. So if there is a constantly result of less than 5 millimeter, it is going in favor of dry eye. One can check tear film breakup time. How we will go for patient looking down, fluorescent strip, wet with saline solution. Again, one of the fallacious thing, we mostly use whatever some antibiotic or sometimes a lubricating drop. It has demulsion. Basically, it will give erroneous result. Ideally, one should use normal saline in these cases, and you have to uh, buy basically shake to remove the extra fluorescein, and one should use cobalt blue filter because there is excitation of fluorescein in these cases. So by this one can see the integrity of conjunctiva and corneal epithelium, although it doesn't stain conjunctival epithelium, but in a study, in different study, it has been shown that if you use yellow blue free yellow filter, its wavelength is of yellow filter is 420 to 510 nanometer, and this yellow filter has wavelength of 510. This blue filter basically from sclera it reflects back, so that is why it is very difficult to see in blue filter or conjunctival staining. But when you use yellow filter, you can be able to see the conjunctival staining. So tear meniscus volume one can see, or stability of the tear film. So one can see the different pattern on staining. There may be diffuse staining. It can be seen in early bacterial infection, viral infection, or there may be some medication, especially when you are using preservative, not free, with preservative medication, topical drops. There may be inferior, it may be due to exposure, or it may be a staphylococcal infection. There may be blepharoconjunctivitis, or there sometimes may be trichitic lash, entropion. It can cause inferior staining. There may be interpalpebral. It mostly goes in favor of dry eye or photokeratopathy, or there may be some inadequate bloom. Superior mostly, if associated with conjunctiva, it goes in favor of SLK, superior limbic keratoconjunctivitis. There may be contact lens induced when you will see on 3 o'clock and 9 o'clock staining. There may be mechanical abrasion or trichiasis, you will see vertical stain. So whenever you see vertical stain and patient is complaining of foreign body, always evert the upper tarsus. Again, there is a new staining system basically in which three types, all the three types, aqueous deficient, decreased wettability, or evaporative dry eye has been basically differentiated into area break, spot break, and random break. In aqueous deficient, there will be area break. In mucus deficient, there will be a spot break, and but in evaporative dry, there will be random break. That is the basically basis of T-butt. When you go for T-butt and there is random appearance of black spot, if same black spot is appearing at the same spot, it means there may be some thinning, some scarring like that, or sometimes elevated spot, edema. So that should be ruled out. If there is a random appearance of black spot, that goes in favor of evaporative dry eye. Staining, I think ma'am has already discussed. Rose Bengal stain, especially it is helpful to stain the conjunctiva also. But the problem with Rose Bengal stain is it is quite irritating. There may be, you can say, a stinging sensation. Uh, Alternative is Lijamin green stain. One can go for Lijamin green stain. There are different staining system. I am already cover von Westerveld, National Eye Institute grading, and Oxford staining. In von Westerveld, only three area was stained: nasal, bulbar conjunctiva, and temporal conjunctiva. But in National Eye Institute grading, 5 area of cornea and 6 area of conjunctiva was stained, evaluated on a scale of 0 to 3. And in Oxford grading, basically it was compared with the set pattern. So this was a National Eye Institute grading. Grade 0, you can see there is no spot. In grade 2, some multiple spot. Grade 1, multiple spot. And these spots are increasing. When you go through the Oxford scanning, basically it can be compared with the whatever you are staining, this pattern can be compared so that you can grade as per Oxford staining system. There are different questionnaire to know the what is the actual complaint of patient. Mostly we rely on examination, a staining pattern, but what patient is feeling, that is mostly ignored. So there is different questionnaire. Most common is the ocular surface disease index, a speed, a standardized patient evaluation of eye dryness, dry eye questionnaire, NEI visual function questionnaire, but most important is the OSDI and dry eye questionnaire 5. So there are 12 questions in different category, and patient is asked to give response all the time, most of the time, half of the time, some of the time, and none of the time. Accordingly, you can grade. And finally, this OSD is calculated with by sum of a score into 25 by number of questions answered. That is the OSDI. Now again I will pose one question. What is OPI? Anybody? Ocular Protection Index. So basically it is calculated on the basis of TBUT, tear film breakup time, by it is divided by tear blink interval, that is ocular protection index. Corneal sensation, again mostly we use cotton based. So corneal sensation, although it is crude, but one should take precaution. Basically it should not go straight, otherwise patient can due to blink reflex, it will patient will blink, or it will touch. Basically it should come outside, and you have to simultaneously touch both the area, same area. Yeah, suppose you are touching the lateral area, temporal part in both the side, you have to compare the temporal part. Second is the just although it is not used so commonly, corset bonnet aesthesiometer. It is a device of 6 centimeter long adjustable monofilament nylon. So basically it is touched, and if patient is not perceiving, its length is decreased. Another is the modified Belmonte. This is non-contact. Other one are contact, even cotton based contact and corset bonnet is contact. So in this non-contact, we can check mechanical different type of a stimulus we can give. Mostly in other we are just giving the touch stimulus, but in this modified Belmonte, we give non-contact mechanical, chemical, and thermal. We can check sensitivity. Coming to the movement gland assessment, It gives clinical evaluation under slit lamp microscope, and structural evaluation, one can just see the lid margin, opening of the lid margin, and assess the orifices, capping, telangiectasia, rounding of the lid margin as posterior lid margin, and functional. One can press the mid tarsal area to see the what type of sebum is coming, whether it is fluid type or sometimes in severe cases you will see toothpaste like material is coming out. So this simple instrument, one can use your auto refractometer for checking this. Infrared myopography, it goes for visualization and quantification of meibomian gland dropouts using photo documentation. Same thing is there, but you can basically, there is a you can document by basically compare the pattern. Advantage is it is non-contact based on infrared imaging, autofluorescence from the normal meibum, and one can check loss of gland, loss of meibum, altered meibum seen as dark lesion. Meibomian gland loss can be assessed quantitatively by meiboscope. So this is the set pattern. So you can compare with the your how patient is presenting. Tear film osmolarity, again it is the upcoming device, although we do not use routinely, but one should know what is the baseline or what is the interocular difference. So basically, ideally, if it is more than 300 milliosmol, it means it is abnormal. But if there is difference between the two eye, more than 8 milliosmol, again it is significant. And in case if it is more than 326, it is severe tear osmolarity. It is handheld device, so one can use basically it touched on the temporal aspect of the eyelid. Tear film interferometry, it allows measurement of lipid layer thickness in nanometer, and it is ocular surface illuminated device with LED. Basically, light is thrown, and this reflected image is basically covered, captured by the charge coupled device camera, and then again it is compared with the normative pattern. So different instrument in the name of LipiView, interferometer, tear science comes. So this is a typical LipiView image. Non-invasive tear film breakup time, I have already discussed. One can in DW, DUGE, non-invasive tear film break time has been taken, while Asia Dry Eye Disease Society, they have taken TBER. That is subjective. Basically, you have to use a metronome to measure the time, because 1, 2, 3, 4 like that, but you may be false. So ideally metronome should be used. So its sensitivity is around 82 to 84%, and specificity is 76 to 94%. And this is the pathological image. Another upcoming device is intersegment OCT. It gives high resolution optical coherence tomography, and one can assess ocular surface disorder. Tear film assessment, it gives a fair amount of basically tear meniscus height, area, volume, depth, and radius. So this is basically height. This one is height, this is area, and this is depth, and this is the contour, whether it is flat, whether it is concave or convex. Again, it gives clue about the tear film. In vivo confocal microscopy, again it is one of the upcoming instrument for dry eye assessment. So it gives structural imaging of the cornea in real time. As compared to OCT, it has a higher lateral resolution, and role in OST is basically assessment of corneal nerve plexuses and goblet cell density. Mostly goblet cell density, when you go subjectively, one can use impression cytology. So basically it is a type of invasive, but with although in vivo focal microscopy it also touches, but not so much like that. So what is its disadvantage? It is single plane of interest can be assessed at a time, and it requires direct contact. I have already told about that. So what it will give, number of nerve per millimeter square, number nerve density in millimeter, number of beading per 100 micron, nerve tortuosity and reflectivity, nerve length and width. So this is a case in which 6 months of cyclosporine has been used in a case of dry eye. So after 6 months, you can see this cell density, it is more regularized compared to this one. And in this one, you can see the number of nerve in subbasal plexus has decreased. Coming to the tortuosity, one can see the straightening of nerve. And keratocyte activation, one can see it has decreased after 6 months of cyclosporine. So basically it gives clue, whatever treatment, especially cyclosporine you are giving, it is working or not. So mostly we give a steroid for very short duration, but you can give cyclosporine for very long duration. There is last one is the inflammatory biomarker. Again, is the one of the investigative modality. It gives clue about the surface inflammation, and it gives clue about the clinically assessed conjunctival hyperemia, lip cough, and most clinically evaluated inflammatory marker is MMP9. Disadvantage is it is semi-quantitative test, and it's high cost. Lip cough is basically appearance of horizontal folds when you examine at the level of tear meniscus. So it gives clue about the chronic inflammation. So this is the instrument for assessment of MMP9. So to summarize, a thorough assessment of ocular surface anatomy and function is essential to know the exact status of ocular surface. History, patient symptom, traditional clinical tests are integrated part of newly described tear film oriented dry eye disease assessment. And use of newer modality helps in quantitative measurement and aid in early diagnosis of the ocular surface disorder. Thank you.